the Asbestos Research Institute is a research institute. It's not a laboratory, but I work closely with them. Okay, so what is asbestos? So, I mean, so basically this talk will just cover everything, summarize things that we've come through before. Please feel free to stop me anytime if you have any questions or after, but a lot of it would probably be revision anyway for you all now. So asbestos is a generic term, basically encompassing fibrous silicate materials. Occurs naturally in the environment. Certainly it is, or was in Australia, mined and used for building materials, insulation, fencing, electrical roofing and flooring particularly, so I think that's very much so with Indonesia. Or concrete framework construction. So fibers are very thin, and so they can float in air and they can inhale into the lungs. So there's 6 types of fibers, but the 3 major types are mined, and they are chrysotile, chrysotolite, and andesite. So those are the 6 fibrous types. So, and that's on histopathology. So we all often do an iron stain, and that's what you can see. So I think, you know, like if you ever get a VATS biopsy, open lung biopsy for interstitial lung disease, and if you want to do, and it comes with a history of pleural plaques or previous asbestos exposure. I mean, the obvious thing is if it's not mesothelioma, then it's not mesothelioma. But then if you see interstitial fibrosis, like a UIP pattern or something like that, then maybe you want to do an iron stain to see whether you can find asbestos bodies.
There's no inflammatory reaction.
Fibrosis. Yeah. Or a UIP pattern. Yeah. So basically asbestos-related lung disease. So I think, you know, the important thing to remember is that asbestos is not just, it doesn't just cause mesothelioma. These are the related diseases that it can cause. So it can, asbestosis, meaning interstitial lung disease, is, you know, due to the asbestos exposure. Pleural effusions, for sure. Pleural plaques and pleural thickening. Asbestos-related lung cancer, you know, adenocarcinoma, that sort of thing. It's definitely way more than malignant mesothelioma, but of course this workshop is centered on malignant mesothelioma. So asbestosis is basically a fibrotic lung disease caused by inflammation as a result of the inhaled asbestos fibers into the lungs. I mean, this results in a usual interstitial pneumonia pattern. So you all have seen a couple of cases of UIP, so you are able to recognize that now. And basically the end result is a fibrotic lung and impaired gas exchange. Because of the fibrosis, the lungs just cannot expand. And so gas exchange or basically air going into lungs is just very restricted. It causes a restrictive lung disease rather than an obstructive lung disease. Obstructive lung disease are things like asthma, COPD, chronic bronchitis, whereas a restrictive lung disease is more ILD type. Pleural effusions, definitely collection of fluid between the lung chest wall. Pleural plaques, calcified. So somebody can have pleural plaques, but not necessarily mesothelioma. They can have mesothelioma without pleural plaques. Is that right? Yeah. And of course, asbestos-related lung cancer, adenocarcinoma, you know, similar to those that are caused by smoking, and it could take up to 20 years. But of course, if they smoke with asbestos exposure, it's even worse. Yeah. Okay, malignant mesothelioma. So it's a rare disease and usually results from previous history of asbestos exposure. About 90% of the cases in industrialized country. There's a long latency period, so it takes about 40 to 50 years after exposure to develop mesothelioma. It's very rare for diseases to occur less than 15 years after exposure, and once diagnosed, the disease is often at an advanced stage because they don't present, you know, very little symptoms. It's a slow onset of degrees. Yeah. So the median overall survival is really between 7 to 12 months after diagnosis, and even with chemotherapy.
Similarly, it's lung cancer.
That's right. Yeah. Except lung cancer, at least you've got better treatment than mesothelioma at the moment. So clinical presentation is very, very non-specific. Clearly, you know, you can have dyspnea due to pleural effusion, chest pain. The chest pain can be due to the tumor infiltrating the chest wall or adjacent structures. Cough and night sweats, fatigue and weight loss associated with malignancy. And if you've got distant sites of disease are uncommon, but otherwise you can have bone, hepatic, or brain metastasis. So radiological modalities is important, and Dr. Aziza is not here, so I can say things. So it's definitely important, and it can provide diagnostic and staging information. Chest X-ray, it's very non-specific and non-sensitive, but at least it can, in advanced diseases, you'll be able to see loss of hemithorax volume, pleural effusion, nodular thickening, irregular visual thickening or pleural masses. CT scan is definitely better. CT shows pleural enhancement, thickening or nodularity of the masses, visual thickening and infiltration of chest wall or mediastinum. But CT cannot reliably differentiate malignant pleural mesothelioma from metastatic malignancy. And it also cannot differentiate between the type of pleural mesothelioma. MRI can provide functional agents like the use of contrast or gadolinium and diffuse weighted imaging with dynamic contrast imaging to provide more functional information. And it's combined with the functional data and usual imaging procedures, it increases the sensitivity and specificity to 90% of differentiating between benign and malignant, but it's not routinely used, and MRI is expensive. There's something what we call PET-CT, and I was speaking to Dr. Aziza, she says there's no PET-CT because it is very expensive. But essentially what PET-CT does is that it injects a substance that measures the metabolism of the lesion. So anything that has a high metabolism, which includes tumor or infection, will show a high SUV. So SUV greater than 2 may suggest benign from malignant, but cannot differentiate pleural malignant mesothelioma over other metastatic disease. So radiology has its place, definitely with regards to benign versus malignant, but it can't really tell you what sort of malignancy it is. When it comes to a late stage, yes, mesothelioma, when it's late, it encases the lungs, crosses fissures, nodules everywhere. But in the early stages, when someone comes with shortness of breath and you see a bit of thickening, you can't tell whether it's from metastatic carcinoma or malignant mesothelioma. So I think that's the important thing, that pathology is still the final judge. Whether this is adenocarcinoma or mesothelioma, or is this benign, or is this malignant.
No pathological, no treatment.
Yeah, no pathology, no treatment. That's right. And no money. So there's no correlation between the SUV and malignant mesothelioma subtype. The false negative is low. There's false negative in low proliferating tumors or early disease. That's right. So if the disease is early, the SUV may not be high. And certainly because it could be false positive to inflammatory conditions like rheumatoid arthritis or collagen vascular disease causing some fibrosis, you have a high uptake. But it's definitely useful in identifying the biopsy site. So if you do a PET-CT, there are areas that are hot and which are not too deep in the lung, then at least the radiologist can say, or the thoracic surgeon can say, yeah, that one there is pretty good for the biopsy, or we can go for that one. And also to identify malignant neural disease from extrathoracic metastasis. So diagnosis of mesothelioma. So it's based on cytological or histological examination of the tissue, and this certainly should be made in context with the appropriate clinical and radiological context, but sometimes you may not have that information. But if through your morphology, immunohistochemistry, extra testing shows that this is mesothelial, and there is invasion or loss of BAT1, MTAP, P16, then you can be sure this is mesothelioma. So, but the gold standard method is obviously histological examination. There used to be a slight controversial whether or not there is a need for histological confirmation of cytological diagnosis, given now the new molecular techniques. But the diagnosis can be made on cytology sample or tissue biopsy sample. And cytology obviously is from pleural fluid, but rarely from FNAs or nodal masses. So tissue biopsy is usually obtained either by radiological guided core biopsy, cryobiopsy, or through fluoroscopy, through the cryobiopsy, or surgical video-associated thoracoscopic biopsy. That's what the VATS biopsy means. So the definitive histological diagnosis of mesothelioma requires the unequivocal, meaning definitive, assessment of malignant mesothelial cells invading into fat or skeletal muscle. So if you have that, you confirm that this is mesothelial origin, you don't need to do your BAT1 MTAP or P16. It's only if you can't see invasion, you've proven that they are mesothelial cells, and you're still worried that this is mesothelioma, then you can do your BAT1 P16 MTAP. But if you see invasion, it confirms mesothelial, it is mesothelioma. Because benign mesothelial proliferation should not invade into fat or skeletal muscle. So depending upon the type of tissue biopsy, this information also may not be available, right? I mean, whether or not, there's previous asbestos exposure. Immunohistochemistry should be done to confirm the cells of mesothelial origin and not metastatic carcinoma. So I think that's the main thing. So ancillary tests may be performed on cell block preparation of cytology specimens and histology specimens. So I think, it comes back to the point where if you're worried, if you're not going to do cell block for every of your cytology specimen, which is fine, because I think, you have to balance that up with your resources, manpower, as well as cost, then I think, you'll have to judge on the cases that you're really worried to then go and do a cell block. And if you're going to go, and if it's an FNA thing, as discussed, then maybe the second pass should be on, on a saline or something, so that you prepare the cell block just in case. If you need it, then at least you've not wasted the material and you've not wasted the occasion from radiology. So ancillary tests include immunohistochemistry and FISH. So loss of BAT1 or MTAP immunohistochemistry is consistent with malignant mesothelioma, and loss of P16 or MTAP by FISH is also consistent with malignant mesothelioma. So just going plural tumors classification, just a very general classification. You clearly have mesothelioma, sarcoma, metastatic carcinoma, metastatic melanoma, and lymphoma. Benign stuff could be solitary fibrous tumor, adenomatoid tumor, or calcifying tumor of the pleura. So this is just the 2015 mesothelioma classification, WHO, which we've covered yesterday, the different types of mesothelioma, epithelioid, biphasic, sarcomatoid. Sarcomatoid includes desmoplastic as well. There is something called well-differentiated papillary mesothelioma, and I'll talk about that later on. It's just very focal. It's well-differentiated because there's papillary. They are mesothelial cells, but there's no invasion. So you've got to be very careful to call this well-differentiated papillary mesothelioma because you've got to be absolutely sure that there's no invasion. So if you only have a little core biopsy, it's actually very difficult to say, because if you're only doing a core on a lesion, you can't really tell whether or not there's invasion on the other side. Very much like a GI biopsy. I'm not sure how many of you do GI biopsies, but if you do a GI biopsy, you've got high-grade dysplasia, but the mass is so big, you don't know whether there's invasive endocarcinoma elsewhere. So it's often that's the case. We say it's at least high-grade dysplasia. You can't confirm or exclude endocarcinoma. So it's the same principle, basically. And not to forget, you've also got, adenomatoid tumor, which is benign. And then you've got other things like lymphoma, which is one of the, the cytology cases. And then you've got your soft tissue tumors, mesenchymal tumors, your synovial sarc, SFT, which an example that you saw. Remember I was talking about epithelioid hemangioendothelioma. It's a low-grade vascular lesion. I don't have an example of it. These other ones are pretty rare. Yeah. Okay, cytology. About 1% of pleural effusions are due to malignant mesothelioma. So it's actually not. Depends on where you work. If you're working in this center, you probably have more because you're a lung center. But if you're working in a big generalized hospital, not necessarily. But if you're in a referral hospital, maybe. And they are often, the important thing to know is that often they are epithelioid subtype that sheds abundant tumor cells into the pleural fluid. It's rarely the sarcomatoid subtype that you'll get anything, because if you can picture the histology, the sarcomatous is so fibrotic, you're not going to shed any cells into the pleural fluid. But the epithelioid type, where you've got lots and lots of cells at the top that they've shed the cells into the pleural fluid, that's why you can diagnose the mesothelioma. So even if your cytology specimen comes back as no mesothelioma, doesn't mean it's not mesothelioma, right? If they look at the CT the radiologist, Dr. Aziz, will be saying, no, it must be mesothelioma. And it's like, no, my pleural fluid has no mesothelioma. then you just have to do a core biopsy and we'll examine it. Even then, it may not necessarily be mesothelioma anyway, right? So I think the important thing is just because it's a negative cytology test, CT scan shows that it is worrying, a biopsy needs to be done.
This is the difficult, the latest difficult to separate mesothelioma from reactive atypical mesothelioma.
Yeah, that's right. And that's difficult. But if you have the BAT1, MTAT, P16 fish
in my dreams.
in your So it is. So I think I understand that you may not necessarily have the right testing here, but as long as you're aware that sometimes maybe for some of those patients that maybe can pay for themselves, or if there's an opportunity, then at least you know that there are techniques that can be done elsewhere for it. I mean, of course, it can't be available to every patient, but as long as you understand that, and if there are cases where you really want to know for academic purposes or for a point, then I'm more than happy for you to send it to me, and I can do the appropriate immunostains for you, and even do fish if I need to.
Is BAP1 and MTAP can be used for another tumor except from mesothelioma?
Yeah, so BAP1 can be lost in malignant melanoma as well. So that's why it's important to make sure that you're dealing with mesothelial cells before you interpret your negative BAT1. But I think as far as Indonesia is concerned, melanoma is probably not that many. But in Australia, it's a lot, so we always think about it. MTAP, I'm not aware of MTAP being used outside of mesothelial cells, but maybe in future other people will find other things. Okay. So mesothelial cytology. So accuracy on cytology alone for diagnosis of mesothelioma is low, but increased with new IHC and FISH methods. The cytological diagnosis of mesothelioma is low compared to tissue biopsy, obviously. So it is important to determine if there is another epithelial component present in the background of mesothelial cell proliferation, or just a single mesothelial cell population. So yesterday's cytology cases is a classic example. We need to make sure that there is no other second population of carcinoma epithelial. It shouldn't be there. If it's there, then it's bad, and it's not mesothelioma. So therefore, they need to perform panel immunohistochemistry. So we talked about that. So that's the from that article. So varying sensitivities and specificities for lung markers. So so again, the message here is that you can't only do one. You really have to do a panel, because you can see that the sensitivity is 75 to 100%. I think Dr. Root noticed how come the CK56 was not as many as the calretinin or that sort of thing, because that some are less sensitive to others. And again, that's the same thing. So yeah. And depending on the organ that you're looking at, then you might want to throw in TTF1 as well. If you're querying, could this be breast, then you might want to do ER/PR if you have. And if it's the renal or peritoneum, you might want to do SAX8, RCC. So it depends. So it very much, you must be aware of what sort of organ system you're dealing with. Is it a pleural effusion, or is this ascites, and is this a male or a female? So varying sensitivity and specificity for both mesothelial and adenocarcinoma markers, recommended to use at least 2, and in addition to TTF1 for lung, obviously. This is because most likely adenocarcinoma metastasis will be from lung. That's your high chances. So that's why I think it's important to have a general adenocarcinoma marker like CEA or Burry P4 and then TTF1. Because if TTF1 is negative but your Burry P4 CEA is positive, then you'll be thinking, maybe this is an adenocarcinoma from other places. And if it's a woman, then you'll have to then ask, is there a breast cancer? And then the clinician probably say, yeah, there was one in the past, and you think, why didn't you tell me? Yeah. So recently, there's a loss of P16 by FISH, and certainly BAT1 and MTAP IHC has been shown to be specific for malignant mesothelioma. So meaning that negative staining for BAT1 and MTAP is pretty good for mesothelioma. But if it's positive, it does not exclude it. It could still be mesothelioma. So it can be very difficult at times if you haven't got any more tissue, if you haven't got evidence of invasion, then at least you can say, I've confirmed that these are mesothelial cells. They are not adenocarcinoma cells. Even if my MTAP and BAP1 is not lost, looking at the radiology, it's encasing, past history of asbestos exposure, then I think this would be consistent with mesothelioma. So now homozygous loss of P16 is an accepted criteria for mesothelioma. I think I've got a couple of images to show you afterwards what the P16 fish loss means. So some papers also report a heterozygous loss of P16 as being consistent with mesothelioma. But P16 loss in epithelioid mesothelioma is about 45 to 86%. So again, it's not that sensitive. The sensitivity ranges from 45 to 86%. So basically you still have, you know, about 50-odd% of cases to 20-odd% of cases that retain P16, but that doesn't mean that they're not malignant mesothelioma. So histology is still important. Can't just do molecular and that's it, you know. So as pathologists are still important. So the loss of nuclear BAP1 IHC is useful to differentiate reactive mesothelial hyperplasia from mesothelioma. They're reported to be 56 to 81% loss in epithelioid mesothelioma. MTAP is a gene adjacent to P16 on chromosome 9 and is often co-deleted, so they're both lost together with P16 in about 90% of cases. So 90% of cases that have P16 loss will also have MTAP loss. And MTAP is good concordance with MTAP IHC, that's why we use MTAP. But P16 has not got good concordance. So this is just a recent article from Hida and colleagues, 51 mesothelioma and 20 reactive mesothelial hyperplasia. You can see the specificity of using one marker alone is all pretty specific. So basically, if it's lost, it's good for mesothelioma. But the sensitivity is different. How well does BAP1 loss or BAP1 IHC pick up true mesothelioma? And you can see it varies. 60% of, if you do only BAP1, MTAP 45%, even worse. But BAP1 IHC and P16 loss increases the sensitivity to 84.3%. And MTAP and BAP1 IHC loss is 76.8%. So, you know, I mean, if you haven't got fish, but that's not too bad. If you have BAP1 and MTAP, your sensitivity increased up to 76.8% instead of just 60.8 or 45% sensitivity. So, but you know, there was another paper from Berg and colleagues, Archive Pathology Lab Med 2018, 20 meso, 17 reactive mesothelial hyperplasia. They compared BAP1 and MTAP IHC sensitivity of 90%. So, you know, they must be very, very good with their immunohistochemistry. And again, specificity of 100%. So I think we're pretty confident that if it's lost, that's going to be mesothelioma, if they are mesothelial cells. So we need to make sure of this. Okay, so just some more pictures, but I think you guys have already seen the examples. BAP1 retained, nuclear staining, BAP1 loss, good positive control are the inflammatory cells. And then MTAP retained, MTAP loss, inflammatory cells, positive control, loss cytoplasmic in the tumor cells. So the biopsy allows histological diagnosis of the tumor and confirmation. And immunohistochemistry is often needed to perform to confirm that the cells are mesothelial and the lineage of the tumor cells if they are not mesothelial. Presence of invasion of fat, skeletal muscle is still needed to confidently diagnose malignant mesothelioma. Otherwise, a diagnosis of atypical mesothelial proliferation, suspicious of mesothelioma, is as far as you can go. But if you use the BAP1 and MTAP and molecular studies, if they are staining correctly, it will then support more definitive diagnosis of mesothelioma. So this was a case that you saw. I think this was the biphasic one, some epithelioid areas invading into fat, and then, yeah. So epithelioid meso has several subtypes. So the architecture of tubular papillary, diffuse, clear cell, deciduoid, pleomorphic. So with the tubular ones, it can be very similar to an adenocarcinoma. So, you know, just bear that in mind. So on morphology alone, it can trick you as well. Nuclei often gland with eosinophilic cytoplasm, but more poorly differentiated tumors may have giant cell nuclei and prominent nucleoli. They often are difficult to separate from carcinoma on morphology, and they may mimic lymphoma when associated with abundant histiocytes. So this one's looking very glandular. Yeah, but actually, same thing here. So that's looking very glandular. That one looks more solid sheets. If someone said to you, that looks like polygyptic squamous cell carcinoma, it could be, couldn't it? And then you just do CK56. Yep, absolutely. Yep, polygyptic squamous cell carcinoma. So you understand now where I'm coming from, yeah? So some more over here, and then you've got nice papillary structures at the top. Yeah. So the prognosis is better than the sarcomatoid or biphasic subtype, but pleomorphic one seems to be similar to the biphasic or sarcomatoid prognosis. So recently, the International Mesothelioma Interest Group have now suggested the grading of epithelioid mesothelioma. I mean, there's tubular type. Morphology has a particular score, mitosis has a score, pleomorphism has a score. So I think there's some studies to show that a particular score shows different prognosis, but it's still yet to be adopted by everybody. Biphasic is a combination of the epithelioid and sarcomatoid elements, and each proportion must be at least about 10% for you to call it biphasic. Any proportion of each component may be present, and diagnosis biphasic will increase as more tumor is sampled. So if you only get the sarcomatous areas, what can you say, right? I mean, but if you get the epithelioid areas as well, so you can say more. So again, so there's the biphasic at low power, you've got the epithelioid areas in sheets and islands. Higher power shows the sarcomatous elements. Higher power even more, showing the epithelioid and the sarcomatous epithelioid biphasic. And some glandular appearances with the biphasic. So differential diagnosis, sarcomatoid carcinoma, obviously. You need to think about that. Synovial sarcoma, but the look of synovial sarcoma is probably more compact, more blue with the sarcomatous elements and more the glandular elements. And BCL2, 99 by Menton for the sarcomatous components. EMA, PAN-CK for the epithelioid component, but maybe patchy in the sarcomatous component. And if you're truly worried, you can do a TFE1 IHC or the FISH for TX18 translocation. So, sarcomatoid mesothelioma, composed of malignant spindle cells arranged in haphazard fascicles, just like fibrosarcoma. Just incidentally, fibrosarcoma is generally out of fashion now. People don't generally diagnose fibrosarcoma anymore. So there's marked pleomorphism and may result in appearances of pleomorphic undifferentiated sarcoma, as in like MFH, the old NFH. Other sarcomatous components like osteosarcoma or chondrosarcoma can also be present in the sarcomatoid meso. That's where they call it the heterologous type elements. So sarcomatoid meso is often negative for all of the other mesothelial markers. As you saw, pancytic keratin really is the only marker that may be positive. And in desmoplastic mesothelioma, pan-CK is most helpful in establishing invasion of the positive atypical cells into adjacent fat. And I think you saw that case, And positive CK in the pleura may be either reactive or neoplastic, hence the requirement of invasion into the adjacent fat to really be sure. Remember how, like the empyema case looked quite ugly, the spindle cells, and you think, oh yeah, this is sarcomatoid. But as it moves down, it just tapers out. So the differential would be between sarcomatoid carcinoma and sarcomatoid meso, and sometimes it can be very difficult to tell. So there are no specific marker, but Claudin-4 and MUC4 apparently may be positive for sarcomatoid carcinoma. So I have MUC4, and I must say I haven't really found it that useful. So I think at the end of the day, when you have a sarcomatous component, you probably have to rely quite a lot on the clinical and radiology to see whether this is going to be better for a sarcomatoid carcinoma or sarcomatoid mesothelioma. Unless it's got loss of that one or something like that, then that'll be helpful. So that was the case that you saw. Spindle cells around fat. And be aware of pseudofat. Remember I was saying? Yeah? Okay? Pseudofat. So just, and if you need to, if you're really concerned, then you can do an S100 to see, because S100 stands positive for the fat cells. But it's good going invasion into fat, cytokeratin, nicely into fat, and another picture of that. So subordinate mesothelioma, BAP1 IHC may be helpful, as loss would be consistent with meso unless it's a melanoma. So once the lineage is consistent with mesothelial origin, then invasion of fat is useful. Loss of P16 also may be helpful. And cases of sarcomedoid carcinoma, like pleomorphic carcinoma invading into the pleura versus primary sarcomedoid, may be difficult, and radiology and clinical is the one that will help you. Desmoplastic, it's a subset of sarcomedoid mesothelioma and desmoplastic mesothelioma. The atypical spindle cells are arranged in a storiform haphazard pattern in at least 50% of tumor. They present in amongst dense sclerotic fibers, collagen necrosis and invasion into adjacent tissue, and lung tissue is helpful for the diagnosis, and certainly will be very easily confused with reactive pleuritis. Conversely, the same thing, reactive pleuritis can look really ugly, and you might be worried about sarcomedoid meso. So I think that for the reasons that we've talked about, it's important to take note of all of those. So that's desmoplastic mesothelioma, just a morphology of it just looks like reactive pleuritis, doesn't it? Yes. So you really need, if that's all I get, I can also just say, look, there's spindle cells, pan-cytokeratin positive, some atypia. This could be reactive pleuritis versus sarcomedoid meso. I cannot tell the difference. You need to correlate it radiologically, clinically, or you need to give me another deeper biopsy, is what I would say in my report. Unless if that one or fish are negative. SFT, so it's a case that you saw, benign mesenchymal lesion. They tend to have hemangiopericytoma-like vasculature. It's usually solitary, nodule on CT or MR. The tumor has hypocellular and hypercellular areas, although the one that you saw, because it was scraping, it was just the hypercellular bit. The hypocellular area contains spindle cells set in the collagen stroma. Malignant SFT exists, more than 4 mitoses per 10, marked cellular atypia with an infiltrated growth pattern. Immunohistochemistry, 34, BCL2 CD99 is positive, and now the new marker will be STAT6. EMA and CK should be negative. If EMA and CK is positive, then you really have to query, is this maybe sarcomedoid carcinoma or something like that. S100 will be useful if you're thinking of neural stuff. So SFT, again, the hypocellular areas in a collagen stroma. Now, well-differentiated papillary mesothelioma. So it certainly is a tumor with papillary pattern. Gland mesothelial cells, they line the papilla. It just grows adjacent along the pleura without underlying invasion. So more common in women and in the peritoneum. And the tumor has a papillary projection with central fibrovascular cause. So the tumor cells are bland, morphology with inconspicuous nucleoli or absent mitoses. Invasion is absent by definition. So if it is invasive, mesothelioma. Malignant, as described there. So that's the RWH. So it's very, very papillary with regards to that as well. So in conclusion, pulmonary non-small cell carcinoma is more common than mesothelioma in a primary pleural malignancy. In the context of mesothelial proliferation, invasion into the adipose tissue or lung tissue or skeletal muscle is the most definitive histological criterion diagnosing mesothelioma. Immunohistochemistry is very important to distinguish between mesothelial origin or tumors of other lineages like metastatic carcinoma or lymphoma or sarcoma. And BAP1 and MTAP-IHC loss seems to be specific for mesothelioma. Molecular testing like P16 deletion by FISH is also specific for mesothelioma. When combined with BAP1 and MTAP-IHC, the sensitivity is increased to 75 to 85%. Sarcomedoid carcinoma and soft tissue tumors may also involve and occur in the pleura, although infrequently, but it's something that you need to remember. And the distinction between sarcomeroid carcinoma versus sarcomeroid meso or even desmoplastic meso may be very difficult and sometimes may require clinical and radiological correlation. And with that, those are the references. So I'll just quickly show you just the pictures of MTAP P16